Thanks, John. It's a pleasure to be here. I was walking in with Janet this morning, and she said, boy, this place has really changed since you were a resident here. And I said, yeah, it's not even the same place anymore. For those of you who are a little younger, it used to be up on the avenues, up on 11th Avenue, which was a beautiful view down the valley when you were spending a late night in the PICU. Disclosures, I am an employee of Geisinger in Danville, Pennsylvania. The Discover project, which I'm going to be hearing about, is in collaboration with Regeneron Pharmaceuticals, but I receive no salary, benefits, or other considerations from Regeneron. Funding for the Adolescent Attitude Survey that I'm going to be talking about came from the NHGRI eMERGE supplement listed there, and I have nothing else to disclose. So I want to start with a patient, a face of our project. This is a 15-year-old girl who was referred for cascade testing after a parent was found to carry a likely pathogenic variant in DSP, which is associated with arrhythmogenic right ventricular dysplasia, or ARVD. This can be associated with cardiomyopathy, abnormal heart rhythm, and sudden death. She's a talented athlete, basketball player. She's experienced a couple of episodes of atypical substernal chest pain not associated with exercise, and she had actually had a normal EKG and an exercise stress test. Her carrier parent had no signs or symptoms of cardiac abnormalities and had a full cardiac evaluation, including a cardiac MRI, which was normal. Her physical examination was normal. We did cascade single-site variant testing. We discussed doing single-site variant testing, and the parents consented to that testing, and the adolescent daughter assented to that testing. So keep that in the back of your mind, because we're going to come back to that at the end of the talk and complete that story. So what I'm going to do is to give you a very brief historical perspective on genetic testing and return of results to pediatric patients. I want to explore the perspective of pediatric patients regarding the return of genomic results, introduce the MyCode Community Health Initiative and Community Engagement and Oversight Project, and then present some proposed research for return of adult onset conditions to pediatric patients. But first, we're going to play Genomics Feud. So if you would take your clickers, I'm going to present to you a couple of cases. Participation will not only for the physicians give you MOC credit, but we're going to be capturing the results not at an individual level, but at an aggregate level. And so you're actually going to be contributing to some of the research in terms of determining physician attitudes. So if you don't want to consent to participating in this research, just don't click. So, but then you don't get your MOC. So I don't know, the IRB may have something to say about coercion related to participation in this study, but it is low risk and should be exempt. So, okay, so here's case number one. A 5-year-old is being evaluated for intellectual disability and autism. Clinical exome sequencing was sent. No primary finding, that is, no cause for the autism intellectual disability was reported. However, the laboratory reported finding a pathogenic variant in the BRCA1 gene. Do you, A, return the BRCA1 result to the family, B, ask the parents whether they want to receive a genetic result that isn't related to intellectual disability autism but could be relevant for the family, C, not return the result as it's not related to the indication for the test, or D, not sure. So why don't you go ahead and vote. Okay, great. So let's see here. I'm not seeing that we captured things here. Let's do it again. Okay, here we go. Whoop, now it's showing. Here we go. Okay, so 3/4 of you thought that we should ask the parents whether they wanted to receive a genetic result. Okay, very good. Only 2% are not sure. That's may reflect a physician audience. I don't know. Because we're always certain, even if we don't know anything. So I read a great quote by Mark Twain. He says, assertion of confidence in the context of ignorance is a recipe for success. And I thought, if that doesn't describe genetics, I don't know what does. So, okay. Case number 2 is a 5-year-old referred to a research project for intellectual disability and autism that includes exome sequencing. The consent says that medically actionable results will be returned to participants. Again, no primary finding was reported. However, the laboratory reported finding a pathogenic variant in the BRCA1 gene, which was confirmed in a clinical laboratory. Do you return the BRCA1 result to the family? Ask the parents whether they want to receive a genetic result that isn't related, not return the result as it is not related to the indication for the test or to the research project, or not sure. So go ahead and vote. Oh, it looks like we have a closed poll here. Let me see if I can go back. Is there a way to open that, or did I mess it up? I messed it up. Okay, so let's just do a show of hands. How many A? Okay, that's about half. How many B? Okay, just a handful. How many C? Almost none. And how about not sure? Okay, one. Okay, so most people hear A. Okay, I'll try not to mess up the poll anymore. Case number 3. This is a 5-year-old who's enrolled in a population health study that includes exome sequencing. So this is a healthy 5-year-old. The consent says that medically actionable results will be returned to participants. Sequence analysis identified a pathogenic variant in the BRCA1 gene, which was confirmed in a clinical lab. Do you return the BRCA1 result to the family? Ask the parents whether they want to receive a genetic result that won't have immediate impact for their child but could be relevant for the family, or not return the result as it isn't relevant until adulthood and recontact at age 18, or not sure. Okay, you can go ahead and vote. Okay. Let's give it a little time. Here we go. So most people would return the result to the family in this context. Okay, very good. Case 4. A 5-year-old presents for a pre-kindergarten anticipatory care visit. Do you, A, perform a full history and physical per AAP guidelines under consent to treat? B, ask the parents if they want to know about any genetic risk that might be identified by the history or physical. C, not discuss history and physical findings that are encountered since this is outside the indication for the examination. Or D, not sure. So please vote. This is what it's taking a little bit longer because people are saying, okay, what is he, they're performing a psychological evaluation on me here. All right, it's interesting. Of course, I think if, without the setup, I think if I'd asked this question first rather than the fourth, I think 100% of you would have said, well, of course, what I do is an H&P by AAP guidelines. That's what we're taught to do. So in some sense, you are exceptional using that term. But let me continue this case, because this is a real case. The only thing different from this case, this is a patient that I saw, was the age. It turned out to be a 2-month evaluation rather than a 5-year evaluation. There was a negative history and family history in this child, but on physical examination, there was a grade 4/6 systolic murmur. Echocardiogram showed a severe hypertrophic cardiomyopathy, which led to a transplant within 1 year because of cardiac failure. Parents and siblings were evaluated for hypertrophic cardiomyopathy. This was prior to the days of genetic testing that we could do, so we had to do clinical evaluation through echocardiogram and things of that nature. So the takeaways are incidental findings can arise anywhere and any time, and sometimes a physical examination is the genetic test. So I wanted to give a little bit of information about how we have thought about return of adult onset conditions to pediatrics over time. But let me also talk a little bit about some of the definitions. So adult onset conditions we define as a condition that have no manifestations and no medical management guidelines in children. An actionable condition is a condition for which predictive genetic results are only actionable in adulthood. So examples for this would be hereditary breast and ovarian cancer related to BRCA1 and 2, Lynch syndrome, which is a predisposition to colorectal and endometrial cancer associated with variants in mismatch repair genes. A non-actionable condition would be an adult onset condition where we don't have any medical management or medical intervention. So things like Huntington disease, where we can clearly say you're going to develop Huntington disease, but there's nothing that we can do to really modify the disease course. So this is a medical definition because, of course, as you're all well aware, people may want to know a result about Huntington's because of lifestyle and life planning indications. But we're looking at it very narrowly through a medical lens for this particular exercise. So returning results for children, the first thing to say is that there's almost no evidence to guide returning genomic results for any condition in children without a medical indication for sequencing. So in other words, there's been very little population-based sequencing in the pediatric population, where it's almost all been indication-based sequencing. The professional guidelines for returning information on adult onset conditions are conflicting and are based on consensus expert opinion and mostly based on presumed psychological and psychosocial harms. So here are some examples of the competing guidelines. So the ACMG guidelines came out in 2013. I sat on the committee that created the list at that time for the 56 genes, where we recommended returning results regardless of age whenever sequencing is done for clinical purposes. That's very important. That gets left out sometimes. But it was then revised after I went off the committee, not saying that those things are related, but needless to say, I would have filed a minority report based on my perspective to suggest an all or none opt-out for secondary findings. So the current ACMG guidelines allows people to decide a priori whether they want to receive secondary finding results or not. The American Academy of Pediatrics guidelines from 2013 recommend do not test children for adult onset disease. So this would be a traditional genetic testing model, which is to say you have a 13-year-old, there's a family risk for, say, hereditary breast and ovarian cancer. They would say do not do BRCA1 and 2 testing because there will be no medical implications for that child until adulthood, and that we should allow the child to have the decisional authority to do that as an adult. And then also, if results do become available, do not return those for an adult onset disease. And then the American Society of Human Genetics in 2015 recommended deferring testing for adult onset until adulthood. However, both the ASHG and AAP acknowledge that there may be reasons to test children for adult onset conditions in the case of extreme psychological distress from not knowing and or after careful deliberation with the family. So there are pros and cons here, and even though I'm representing them in a balance, it's not necessarily balanced in the view of most folks. Information is powerful. Early prevention may have an effective, it may have an effect on the family, although again, it wouldn't be relevant for the children. Identification of at-risk family members is the biggest idea, the idea that there could be harm to a child if a parent develops a cancer or some other condition related to a secondary finding that occurred in testing for the child, and that identifying that and intervening with the parent could have benefit by not depriving that child of a parent, and then identifying new conditions in the family. On the con side, it is somewhat paternalistic to define what you can and can't do. There's concerns about the loss of the child's autonomy for decision making. If we return the result, then they lose that. There's no medical recommendations for children. Obviously, there's no interventions that we would do in childhood. And the concern that parents may treat the child differently, the so-called vulnerable child effect. The proposed psychological harms are primarily related to anecdotal reports from receiving results for adult onset conditions. It would be fair to state that there are also anecdotal reports of harms from not returning results in adult onset conditions. Breast cancer risk is one that has received a lot of discussion, particularly due to concerns about the effect on self-image in young girls. However, it's important to recognize that there's been no consistent empirical evidence to support this concern, or really empirical evidence around any of this. So most of these guidelines have come about from a bunch of people that have an interest in the topic, sitting around a table and coming to a consensus about what they think would be a best practice. So the ethical dilemma really comes about harms in childhood, and this would be results for adult onset conditions, particularly breast cancer, inflicts psychosocial harms on children that outweigh the benefits from returning this, and the right to an open future. Children have a right to decide whether they want to learn these results once they reach a legal age of adulthood. So let me step away from this for just a second and provide a backdrop of what we're doing at Geisinger so you can understand why we have a particular interest in this topic. So we are doing a large-scale population-based exome sequencing study at Geisinger, where ultimately 250,000 patients will have their exomes sequenced without a medical indication, but just as part of participation in this large research project. Those exomes will be analyzed for medically actionable results, and we will return results to patients and providers. That is a condition of consenting to be in this project. We'll support the patients and providers in follow-up to the results in a long-term management plan, and we're operationalizing a scalable genomic return to results infrastructure within our large integrated healthcare delivery system. Now, the backdrop for this goes back about 10 years when we started a biorepository. This was following extensive consultation with our patients and other stakeholders that informed the design of the project. But when we moved to the idea of doing this large-scale exome sequencing, we redefined this as a community health initiative as opposed to a biorepository, because now we had the evidence that we could actually return results to individuals that could have an impact in their medical care. And so we really are beginning to look at this as a population health initiative. This biorepository includes pediatric participants. The community favored inclusion of children when we consulted with them, and this was hundreds of Geisinger patients through interviews and focus groups. Our youngest enrolled patient, we had two parents who were MyCode enrollees, and they said, we want our baby in. We got a sample off of the cord blood. So right after the baby was delivered, and the cord blood was obtained, a MyCode tube was sent. So the earliest enrollment was about 2 minutes. So we have less electronic health record data on that particular individual. So the participants in this study sign a broad consent that allows combination of the electronic health record data, a median of 12 years of data that's prospective and can be de-identified or under certain circumstances re-identified, and also biospecimens, mostly DNA, but other biospecimens in certain circumstances. And the consent includes the ability to recontact participants for future projects and to communicate medically actionable results. And so if people don't want to be recontacted, or if they don't want to receive results, then they are not allowed to participate in this project. Because our feeling is if we have these results based on the community engagement, that we are obliged to return those results. So we don't want to put ourselves or our patients in the population of saying, well, I want to participate, but I don't have result. We have a result, and then they develop the condition, and then they say, well, I really wish you would have told me that. And I said, well, you consented and said you didn't want that, but I changed my mind. That would be a nightmare. So we're basically trying to keep it as clean as we can. Right now, actually, the update is we have over 166,000 consented participants, and 92,000 of them have completed exome sequencing. Our return of results is focused on 76 genes, which is inclusive of the ACMG 56. Now, we're going to be modifying to go up to about 80 genes, probably as of tomorrow. Of course, ACMG now has 59 genes. So our list will always include the ACMG list as that's updated. Most of these are cancer predisposition genes like BRCA1 and 2, cardiovascular genes related to familial hypercholesterolemia, cardiomyopathies, et cetera. But then a few rarer disorders, things like malignant hyperthermia, hereditary hemorrhagic telangiectasia, and ornithine transcarbamylase deficiency. 25 of the 27 conditions can have onset in childhood. The exceptions are HBOC and Lynch syndrome. We have an extensive governance structure. We have a community advisory board. We have a clinician advisory board. We just started a Precision Health Youth Advisory Council, which I'm going to talk about in a little bit more detail. We have an external ethics advisory council that consists of 4 community members and 4 ethicists. That's going to be expanded. The latest recommendation was 8 community members. The IRB, a genomics council, which consists of all of the geneticists, counselors, and other interested parties throughout the system, and then the MyCode governing board. The IRB and the MyCode governing board are the only 2 groups that have decisional authority about what is done or not done. The rest all provide input, which is attended to very significantly as IRB and MyCode governing board make their decisions. So the Precision Health Youth Advisory Council just started up in June of this year. We have faculty facilitators, including Janet. So we have an ethicist and a couple of our genetic counselors. I will point out this is not a picture of our, this would be like, this is the Intermountain Youth Advisory Council. You would look at that and say, really? No. Okay, because we're a little bit like Intermountain in terms of our diversity, which is not quite where it's, if you consider Germans and Italians diverse, then we're diverse. But beyond that, it's, I don't know, would you consider, Nicola, that's pretty diverse, isn't it? Yeah, I would say so. So, okay, here we go. Let's go forward. So this really follows from a World Health Organization document, and this is one pull quote from that document. This is, adolescent leadership and participation should be institutionalized. Now, I might have chosen a different word there. You know, I think that has connotations that are a little beyond what I would have, you know, but in any case, I think they meant it in a positive way. And actively supported during the design, implementation, monitoring, and evaluation of adolescent health programs, which we think is very important. And clearly, since this project is involving adolescents, we've convened this. So all of the members share ideas and provide meaningful input and ongoing feedback on specific research policies, protocols, and priorities for the precision health projects at Geisinger. The current pilot is based in Danville, and we have 7 members between the ages of 14 and 17. These members earn volunteer hours for their attendance and participation in monthly meetings, and they also get pizza. Applications are accepted on a rolling basis and reviewed once a year for council terms running from June to May. So that's sort of a backdrop of what it is we're actually doing. Now let's return to the issue at hand, which is the return of adult onset conditions to pediatric patients. So I don't know why it doesn't want to keep going here. Okay, here we go. So the coming back to the this childhood harms and the right to the open future. So the childhood harm argument, actually, from an ethical perspective, is a consequentialist argument, and we can actually empirically test that through well-designed research studies. The right to an open future is actually a deontological argument, and what that means is it's either right or it's wrong. You believe it's right or you believe it's wrong, and it's really not empirically testable. Although you can ask about people's attitudes, you really can't test this in an intervention sense. So we have an overarching research question, which is, how should we ethically manage genomic results concerning adult onset disorders for pediatric and adolescent MyCode Biobank participants? And before I move on, I should come back to one thing. I mentioned earlier in the slide that 25 of the 27 conditions can have onset in childhood. All of our advisory groups have said those results should be returned to the children and their families. So for those 25 conditions, those are being returned when they're identified. So it's only the 2, hereditary breast ovarian cancer and Lynch syndrome, for which this consequent discussion is relevant. So our approach is to assess the attitudes of parents towards the return of genomic information in children from a biobank and explore differences in pediatric versus adult onset conditions, but also to explore the attitudes of adolescents regarding genetic testing for adult onset conditions. So let's start with parental attitudes here. So our initial study was a qualitative study where we used a focus group design and we used deliberative engagement with education followed by a structured discussion. Education, discussion of professional guidelines and the ethical dilemma. And then we structured the discussion of 2 scenarios of healthy people learning genomic health information and education about the conditions. One of them was a condition with immediate medical implications, meaning it could be relevant to a pediatric patient. The second was an actionable adult onset condition without medical implications in childhood. Our participants were adult MyCode participants who had children enrolled in MyCode. So these are people with skin in the game. They've actually not only are enrolled themselves, but also have their child enrolled. So this is a scenario that could potentially result. The groups, we decided it would be worthwhile to split them by the child's age. So we had groups where the children were in the 0 to 8 age range, and then 9 to 17. That was sort of an arbitrary distinction. We actually, I think traditionally for research projects, assent in childhood is around age 9. For our MyCode project, we actually begin the assenting process at age 7. None of these individuals have received genomic results as a result of MyCode participation to this point, because we didn't want to necessarily, we want all of this to be in the hypothetical space as opposed to, oh, I actually have to deal with this issue. All of these children are healthy with no currently identified genetic disease. We had 17 parents that participated, 3 dads and 14 moms. I think that's probably typical. And then we had one 16-year-old boy that attended with his father, and we didn't make him sit out in the hall. We used a discussion guide where we brought up several different concepts. The value of information to a parent versus a child's choice in an open future. Impact of the results on the child and the parent and their relationship. How parents would want to hear results. What parents would do with the results. How, when, and why parents would tell their children, and whether or not these results should be included in the child's electronic health record. The discussion scenarios that we used were a pediatric onset condition, Marfan syndrome, and some of you may know the story of Isaiah Austin, who was a very talented college basketball player, was drafted in the first round of the NBA, but in a physical examination was noted to have a dilated aortic root. Diagnosed with Marfan syndrome, was basically not allowed to play in the NBA, but he's become a very strong advocate for Marfan syndrome. And then the second is an adult onset scenario, again, using a adult onset cancer condition and the impact on children. And so these are both drawn from popular press articles that provided the backdrop. We asked, why did you sign your child up for MyCode? We thought that would be a very interesting question. It was. I'm not going to present any of those results today. And then the questions that I had listed on the prior slide. And then we did that for the pediatric and adult result in the two groups, and then for the adult result only. That was our analytic framework. This is what we found regardless of scenario. Parents don't consider genetic information to be exceptional. They consider it to be similar to other information. So here's a couple of pull quotes. I look at it no differently than what my blood pressure was, my temperature. You may never be ready for potentially bad news, but it doesn't change what's going on in your body, you know. And another, it's kind of like a peanut allergy, you know. Everybody's got to know. And we didn't have anybody that, you know, said, oh, this information is clearly different from the rest of my medical information. So that's a very different perspective, I think, than most of us have held in genetics over the last 20 years. Specific opinions for adult onset disorders. The anticipated impact, and again, this is hypothetical, they would not treat the child differently after learning the result. They might still change some behaviors or activities to be healthy. So for example, if you have Lynch syndrome, there are certain dietary interventions that can be used that seems to have some impact on lowering the risk for developing colorectal cancer. So that would be something that said we might consider doing something like that. They would also prepare the child for the management of risk for when they reach adulthood. So basically make the case, these are the things that you're going to need to do at some point when you're adult, so be ready to do that. In terms of when, where, and how to tell the child, they would really tailor the conversation over time based on the child's maturity. And they also would relate it to family history, which I thought was very interesting. So they would say, well, you know, this is why grandma or aunt, you know, developed cancer or that. Now, of course, not everybody has a family history of one of these disorders, but when it was there, they said this would be a very good way that they could tie this specific discussion into the family history itself. They absolutely thought that this genomic information needed to be in the electronic health record, regardless of how the parents felt about knowing. They expect us, the medical system, to use the information for their child's health when they transition into adulthood. One parent, and if that was in her file and they knew she had this predisposition, maybe they would test for something that they wouldn't test you or I or somebody for, and it would be detected early just because that was there. And if you didn't know about it and you didn't get tested, then what? The parents really didn't want to engage in consideration of the child's loss of autonomy or right to an open future. That was not something that they thought was relevant to this discussion. They believed that the parental choice and the need to protect and the concern for the future outweighs the child's choice at that point. I don't see where some kid is going to say, you ruined my life by getting me tested and now I have to be watchful for stuff that might happen to me later in life, you know? I don't care if you're saving my life, darn you. I thought that was a great quote. I love that. Although I can imagine some kids actually saying that. So in conclusion, the parents were interested in results for both pediatric and adult onset conditions with medical management guidelines. Parents wanted control when and how they tell their children and to have a continuous conversation over time that would involve the medical profession as well. The practice implications as we take it from this, albeit small sample, which I would consider to be preliminary data, that parental thoughts and feelings may differ from current guidelines, and are important to consider in program and research development. And engagement of parents through deliberative discussions is effective at eliciting their opinions and helping researchers and clinicians understand their perspective on these complex ethical issues. And again, I would reinforce that almost none of the guideline discussions incorporate any, even a relatively small study like this, to get the perspectives beyond what we as physicians think is the right or wrong thing to do. Physicians, counselors, and other things like that. So how about adolescence? Well, this was a fortuitous, we were thinking about this, and then in 2016, ASHG has a DNA Day essay contest every year. This comes out on April the 25th, which is DNA Day. That marks the date of the publication of the Watson-Crick paper in 1953. It also was the date that our older daughter was born, which I think is cool. We have two geneticists that have a daughter born on DNA Day, born at the University of Utah Hospital here. And not that there was a DNA Day back then, but nonetheless, we're claiming it. So here was the question in 2016. Adolescents should be encouraged to defer predictive or predispositional testing to adult onset conditions until adulthood because of the complexity of the potential impact of the information at formative life stages. Well, we saw this and we said, whoa, this is really cool. So we contacted our friends at ASHG and said, so when people submit those essays, are you allowed to do research on them? He says, yep, that's part of the consent. He said, are you going to do any research on it? He says, no. We don't have any resources to do it. So we collect the essays, we award the winners, and that's the end of it. Would you be interested in partnering, perhaps, in doing this? Because we think there might be some really interesting information. They said, if you can get the money, we'll partner with you. So our approach, 1,241 essays submitted from 9th to 12th grade students, of which over 1,000 were from the United States. And you can see here that there's a broad distribution across, although there's only one from Utah. It's a little bit disappointing, I would say, for the students here, but you know, again, what are you going to do? All of these essays were coded by ASHG for student age, their sex, the disease that they chose to write about, because they could choose a disease, and their preference to defer or not defer testing to adulthood. We also were able to derive some demographic statistics because information about the schools is presented along with the essay, and so we can go to publicly available data to look for the percentage of sponsored lunches and things like that to get an idea of what the socioeconomic mix of that particular school might be. We then developed a code book for reasons of why to defer and not defer. And so we submitted this as a supplement to our electronic medical records and genomics grant. We were awarded that supplement from the NHGRI. That included ASHG, Geisinger, and we used genetic counseling students from Sarah Lawrence to actually do the review coding and that. So it was an opportunity for them to do a research project that was relevant to their profession. So it was a wonderful opportunity to also teach them how to do this type of qualitative research. More girls submitted essays than boys. Again, I'm not sure that that's surprising. There were many different conditions that were chosen, and there was a nearly 50-50 split if you look at the aggregate about to defer or not to defer. Interestingly enough, even though the instructions said, you know, a medically actionable adult onset disease, about 1/3 of the sample chose Huntington disease, which we would not, in that broad or that narrow definition that I gave you earlier, define as actionable. But clearly, they're thinking about actionability in a very different way, not from that medical perspective. So this was great, and for the purposes of what we're going to talk about, we'll defer Huntington, because actually that we're using another 4 students from Sarah Lawrence to do just the Huntington piece, so that's ongoing, and so stay tuned for that. And then we reviewed the difference by condition. So you can see here that BRCA was the second most popular. Alzheimer's, again, one we would not necessarily consider to be relevant, was chosen frequently, and then familial adenomatous polyposis, which actually we would consider to be a pediatric return of result condition, and then hemochromatosis. If you look at Alzheimer's versus BRCA, you can see some differences. So for Alzheimer's, about 2/3 of the adolescents said deferring testing until adulthood would be appropriate. Whereas in BRCA, it's not quite reversed, but there's definitely a trend that shows that more individuals, the majority of individuals, would prefer to not defer return results for Alzheimer's in the pediatric population. Here are just some examples. 12-year-old, a senior girl from HBOC that wants to defer that. It is wrong for a teenager to be tested for breast cancer because the child is too young to know if this disease will even be applicable to them when they grow older. Tests will only increase stress among the family and the child. The child may not even end up with cancer. As opposed to a 9th grade male, I disagree with the ASHG statement when it comes to Huntington disease. To plan for the future and decrease stress, those who are mentally fit should take a predictive test for Huntington disease. Now, there are limitations to this study mechanism. These are the opinions of school children enrolled in an essay contest, so it's pretty uncontrolled. The teachers submitted essays on behalf of each student, and there were some limits. They could only submit up to 6 essays per class for up to 3 classes. So we did look to make sure that we weren't getting, that there were just certain teachers that, were insisting that people do this, and so they were sending in a lot of studies. And it looks like that's not going to be a significant issue of bias for this particular study. So the lessons learned here are engaging stakeholders that are most impacted by the issue is an effective way to understand their views and guide program development. Parents and children may value the information over the concerns about the information, and both parents and children also have concerns about the information and express the need for individual choice. So further research is needed to empirically test the impact on children and families from adult onset information, which brings us to future research and our plans of what we're going to do. So our project, the MyCode project, actually provides us an opportunity to address this question. So we've had a lot of internal discussion about whether and how to return pediatric results within MyCode. Our Ethics Advisory Council said this is a reasonable thing to study so that we can return these results, but we should only do it within the context of a research study. And so we're putting together an R01 that will go to the NHGRI's ELSI program, returning adult onset genomic findings to pediatric biobank participants. Our specific aims are to determine whether psychosocial outcomes differ among those who receive an adult onset result, those who receive a pediatric onset result, and those who do not receive a genomic result. In other words, we didn't find anything, which is the majority of individuals. About 3.5% of the population have a pathogenic variant in one of the 76 genes that we identify. The specific aim, too, is to assess the participants' health behaviors, including healthcare utilization, associated with receiving a genomic result for an adult or pediatric onset condition, and examine and monitor the loss of chance tort doctrine and its applicability to return adult onset genomic results to children. So this is our study. We'll have group 1 where there's a possible pathogenic variant for an adult onset condition, HBOC or Lynch. They would be approached for study participation. If they don't agree to participate in the study, what we will do is defer return of that result until 18 years of age when we would approach them for reconsent, at which time we could return that result after clinical confirmation. If they agree to participate in the study, we'll do a clinical confirmation. The exomes are done in a research setting, so before we can return them into the clinic, we have to do a clinical confirmation with a report being issued. And then we would return that results within the context of the research protocol. Group 2 would be a pathogenic variant in a pediatric onset condition. Again, they would be approached for study participation. If they did not want to participate, then we would confirm the result and return that as part of our clinical return of results program. But if they wanted to participate, then we do the clinical confirmation and return that result within the context of the research protocol. And then group 3, where there's no pathogenic variant, again, we would approach for study participation. If they weren't interested, that would be the end of it. If they did, then we would return negative results within the research protocol. Now, it's important to point out that because our analysis of the exomes, we know is not perfect, that technology is going to change, our knowledge about variants is going to change, we don't return negative results. So if you're in MyCode, what we say is we will not contact you and say, hey, we didn't find anything. So it's really the no news is no news, because we didn't want people to make health decisions based on information. We said, well, I had testing for that, so I'm not going to go forward. And this is a problem we encounter in pediatrics with newborn screening, isn't it? Where somebody says, well, I don't need to test this person for cystic fibrosis, even though they've got all the signs and symptoms, because they had a negative newborn screen. Well, it's not 100%, and it's certainly true that our exome analysis is not 100%, so we didn't want to set up that type of a scenario. But under the context of this research project, we would return negative results for the purposes of learning. So this is very early, so stay tuned. I hope to be able to return at some point and present the results of that study. So I want to come back now to our patient. She tested positive for that familial variant, and she was referred to cardiology. She had a cardiac MR. That was normal, and there was no evidence for ARVD at this time. She will also have an extended Holter monitor to look for evidence of cardiac arrhythmias. This is pretty important because the most common cause of sudden death in athletes are these arrhythmogenic disorders, whether it's cardiomyopathy or one of the inherited long QT syndromes. At present, there will be no medications or activity changes recommended, but this is something where she now will have ongoing monitoring, hopefully to prevent an episode where she would have a sudden death. Okay, now we're back to genomics feud. So again, pull up your things, and we're going to see if there's been if I've been convincing at all. Not that I've been trying to convince you, but just kind of lay things out. So let's go back to case 1. Again, this is our 5-year-old who is clinically evaluated for intellectual disability and autism. No primary findings, but there is a BRCA finding. Would you return the result to the family, ask the parents whether they want to receive a genetic result that isn't related but could be relevant, not return the result as it's not related, indication for the test or not sure? So go ahead and vote. Okay. So I think we're right about where we were. I think if I recall correctly, we were about 76%, and now we're about 68% with a little bit of increase in A. So I'm not sure that is statistically significant with an N of 38, but maybe I've been just slightly convincing in terms of that perspective. Case 2, this is the 5-year-old who's involved in a research project for intellectual disability and autism, where a BRCA result is found. So again, return the BRCA result to the family, ask the parents whether they want to receive the result, not return the result, or not sure. So please go ahead and vote. Okay, that's actually changed a bit as well. I think if my recollection is, well, actually this is the one I messed up, but based on the show of hands, the first time around, the vast majority of folks were in A with only a handful in B, and now we have about a third of the attendees in the B category. Case 3 is obviously the MyCode project, which you now know. And so what do you think we should do? Return the result? Ask the parents whether they want to receive the result that won't have immediate impact, or not return the result, and then recontact the individual at 18 for reconsent and return at that time. So go ahead and vote. All right, and that's shifted significantly because my recollection was that in our first vote, the primary response there was B. So I will. I know those results will be distributed and available if you're interested. But it's interesting to see that there has been at least a little bit of an impact in terms of what we presented here. Thank you very much for participating in this brief, uncontrolled, and completely non-rigorous research study that I'm sure will be published in the New England Journal. So I want to thank all of our MyCode participants, which now are over 166,000 of our Geisinger patients, my collaborators through the Discover project, both at Regeneron and at Geisinger. I shamelessly borrowed with permission slides from colleagues Mike Murray, Alana Ram, Jennifer Wagner, and Adam Buchanan. And I also want to thank NHGRI, ASHG, Sarah Lawrence, Gen Counseling faculty and students, specifically related to the Adolescent Attitude Survey. Thank you, and I think we have time for questions.
Thank you. That was very interesting. I'm curious about another aspect of this testing. How many couples who've participated in this have had to have genetic counseling because they were found to have two alleles of an autosomal recessive gene that might be deleterious to their children?
Right.
So this is the other,
right.
the other side of that.
So at the present time, we're not returning carrier results. It's a very relevant question. So if we have a situation where in our 76 genes, we find individuals where you say the mother has a pathogenic variant in BRCA1 and the father has a pathogenic in BRCA2, then we would clearly, counsel them regarding their risks and results. And in that context, we would say, and there is the possibility that you could have a child that might have both, and that might confer increased risk. So that would be a scenario, and we see this in Lynch syndrome, where in certain circumstances where you have biallelic inheritance through both sides of the family, we now have a childhood onset condition. So we would be able to identify that, and we would return that result because it would make a difference for the child, even though it's Lynch syndrome, which is technically an adult onset condition. To my knowledge, we have not experienced that as of yet, although interestingly, we've returned 420 results to participants so far on 420 results to 417 participants. So there are 3 participants who have 2 pathogenic results just by luck of the draw. So this is one of those scenarios that we were expecting to find, that we would see individuals that have risk for more than one disease as a consequence of exome sequencing, and that is in fact the case.
You only return it to them if not the offspring.
That is correct, right? So, and there's a couple of there's a pragmatic rationale for that. Well, there's 2 pragmatic rationales for that. The first is that the median age of our participants are over 60. So for most of them, it's kind of irrelevant, we think, for the majority of them. The second one is because these are done in research setting, we would have to do clinical confirmation. So right now, that's coming out of our research pocket. And so what we can reasonably afford to do is to confirm the 3.5% that have one of these pathogenic variants. If we're able to develop some sort of a low cost way to look at things like carrier testing, pharmacogenomics, where we would really be doing that for almost all the population, we would begin to develop strategies to return those results. Yeah, Josh.
Mark, that was fantastic. My head is spinning with ideas and thoughts, but I'm going to limit myself to one comment and then 2 follow-up questions.
Okay.
The first is, so as you know, in cancer, and specifically in pediatric cancer, this has become a huge issue with somatic testing, where you get these unintentional results of germline. The way we've set up our pediatric biobank protocol here, where we try to enroll all of our pediatric cancer patients, is we actually take care of that question up front. So in the consent, we have basically information that says we will contact you if we find something that is potentially clinically actionable, and then we'll give you the decision at that point in time to decide whether or not. So they already know that we may be calling them and say, hey, do you want this information or not? So the 2 questions.
So can I ask you a question about that?
Of course.
Why don't you think that's relevant to your pediatric cancer patient, that you have a pathogenic variant? Are you asking?
No, it is relevant, but this is for germline testing. So if we do,
but even so, I mean, you have a pediatric kid with cancer,
yes,
and so even though we don't think that BRCA1 and that or Lynch, but if you have a mismatch with something else, I would say that that's highly relevant and maybe in part the explanation for why that child developed cancer.
Absolutely, and these are the big national studies, as you know. Do these adult onset, do they affect? And then there's actually treatment-related issues down, like PARP inhibitors.
PARP inhibitors, exactly right,
but in terms of just returning the results to the parents for all of these conditions, we ask when we're consenting up front, we basically plant the seed in their head and say, listen, we're going to contact you later on, and then we'll have a discussion whether you want the results returned. All right. Anyways, so 2 questions. So the first is, in this amazing, awesome study, how are you actually making the calls, and how do you decide what's a VUS and
Right.
what's not, and what algorithm are you using? Because that
Right.
makes all the difference.
Right.
And then the second question is, how are you collecting family history and integrating
Right.
that into your study
Great.
practically?
So those are excellent questions. The first one is that because this is non-indication-based testing, this is essentially screening, we have zero interest in sorting out VUSs. Because what we know, and it's amazing how many people in this field who are trained in genetics forget about Bayes' theorem. They're forgetting about the prior probability. And so a lot of the clinical laboratories that are doing secondary results analysis, secondary findings analysis, are applying a clinical indication-based approach to calling those variants, which is entirely the wrong thing to do. Because the prior probability that you're going to find one of these, let's say BRCA1, is about 1 in 400. And so if you are more generous in terms of considering VUSs, the overwhelming majority of those are going to be false positives. And so you're going to be returning results that really are not relevant. And so for our analysis, of course, you're using standard bioinformatic calling pipelines and that sort of thing. But in terms of the variant annotations, the ones that we're looking at are ones that have star 3 or higher evidence in ClinGen, or are clearly associated with like an Ashkenazi Jewish variant in BRCA1. And then in the clinical confirmatory testing, we have a second analysis of that variant annotation by an independent laboratory to make sure that our assertion of potential pathogenicity is consistent with theirs. But if it comes out less than likely pathogenic, we do not return it because of the risk of false positives. So what we're trying to do is to get our specificity as high as possible, because the point is not to identify everybody in the population and to have high sensitivity because of the risk of the false positive. And then the family history piece, we're not systematically collecting family history on every MyCode participant, but at the time of a return a result, then we get a 3-generation family history by one of our genetic counselors, genetic medicine assistants, so that we can look to see, does a family manifest a pattern that would be characteristic. Part of that is to identify at-risk family members, because cascade screening is part of our project, but also then to contextualize the result and say, okay, we can really believe this one because we're seeing a family history that's very consistent with this particular result. And that's important from our analysis perspective as well. Other questions? John has one down here.
So Mark, that was really stimulating and informative. Thank you. A question and comment. My question is, in your pilot study, which must be from the Danville region, what do you have a sense of the socioeconomic, educational level, and even perhaps not taking family histories, but even the ancestry? Are they all the German, Italian,
Right.
Irish group? That's my question. Maybe
Right.
then I have a comment.
Yeah, so the question is, we have done some analysis like that. James Carville refers to Pennsylvania as Pittsburgh in the west, Philadelphia in the east, and Mississippi in between. And so we're in the middle of Mississippi. And it's fairly accurate in the sense that if you remove race and ethnicity and you look at socioeconomic status, educational status, health, we're almost identical. You can't really distinguish which is Mississippi, which is central Pennsylvania. Now, it turns out our MyCode group has slightly more education on average than our average population, which was a little bit of a surprise because we thought with the numbers that we were dealing with, we wouldn't see much of that type of a selection. But we do see a little bit of an increase, but it's not the typical study where everybody has postgraduate degrees. It's still representative of folks in our region where there's just more people that have completed high school, a few more people that have actually gone on to college. Socioeconomic-wise, we haven't done any in-depth analysis of that, but we do know that we're relatively a depressed area. There's, other than healthcare, there's really not any big industries. Danville's a town of 8,000 people, for which 14,000 people come to work every day in the medical center. So we know we're one of the bigger drivers. And of course, because a lot of our employees are also members of My Code, that's also probably driving some of that increased educational attainment piece as well.
I asked, of course, because
and the relatedness issue is that we are actually doing we're using something called Primus, which allows us to look at the exome data and look at relatedness. We've got some information that's just coming out, but there's a lot of relatedness in this population down to the third degree relative level. It's not enough to really bias what we're finding, but we are in particular identifying what appear to be founder variants in certain diseases that are occurring at very high frequency that had never been seen in any of the other published databases.
I asked the question, of course, because as you know, African Americans have rather novel views toward genetic testing,
yes,
looking at it in different ways. But my comment is that I'm not sure I'm going to be able to articulate this, and maybe it's the closing comment, but I realized during your presentation that 45 years ago when I was an intern, half the audience would be smoking in a room like this.
Yeah.
Even at grand rounds
Yeah.
at UCSF,
Yeah.
when I was a third-year resident,
Mm-hmm.
the culture about smoking has completely changed. I mean, I know there's still, women who are pregnant, 21% smoke cigarettes nationally, so we have a lot of work to do, but the culture has changed. And I think I'm getting some feeling, even as a geneticist, that our whole culture around views toward genetic disease and testing and medicine, maybe it's only among the people I talk to, but that's changing.
Right.
And we're going to have a change in the culture around health.
Yeah, so what I would say two things to that. One is I think we're trying to change the culture of exceptionalism within the medical profession. The only time we ever hear comments about genetics information being different is when it's one of our employees that's participating in the focus groups. I would argue that the culture of non-medicine doesn't look at this information as being different. It's just one more piece of information that they expect physicians to use to manage their healthcare. So while we've done a great job of trying to create this frightening environment of exceptionalism in genetics, one of the worst things about the Human Genome Project, and one of the best things about the Human Genome Project, was devoting 5% of the monies to ELSI, because it convened a lot of people, smart people in a room to sit around and dream up doomsday scenarios about what could potentially go wrong, almost none of which have actually gone wrong. So I think there's going to be a culture change where I think we're going to see the very same thing that we saw in HIV/AIDS and other things that were considered to be extremely highly sensitive, where now, all of the protections that had been put in place related to that are essentially going away, because we realize the harms of treating that information as exceptional outweigh the benefits of using it in medical care.
Thank you for not smoking today, and thank you, Dr. Williams.